Now, Niraj, these trials have different levels of follow-up. Some of these studies have just come out. Other ones, I think you mentioned, the 214 data was just presented, 42-month follow-up data. How much of that factors into your comfort level in a recommendation for this frontline treatment, not necessarily having that 3 or 4 year follow-up data? Is that an issue for you? Is that something you feel comfortable still, recommending some of these newer regimens?
Yes, definitely. A longer follow-up uh, is always compelling for me, especially when I'm looking at the durability of complete response, which is the basis for me to even, which is the first thing which comes to my mind when I think about EP-Nivo. So yes, 42-month follow-up is a big deal, and it continues to reinforce that this regimen induces those durable complete responses, at least until now. But not necessarily in the context of VEGF TKI-based regimens. When I'm really not counting on complete responses, as Reina said, Monty said, there are many patients who are going to be candidates for VEGF TKI plus IO combinations. And, uh, and for those, I think, regimens, I'm not really, durability of complete response may not matter as much as the overall response data or PFS data or OS data or the absolute OS data. So I think it's relative. I don't expect, for example, cabozantinib to induce durable complete responses for like 5 years. Although I have patients, both on Meteor trial and the original sunitinib trial, which randomized patients to 50 milligram every day versus 37.5 milligram. And I have a patient still respond to sunitinib from that trial. But at the same time, I think, you know, cabozantinib, I'm not expecting cabozantinib to show 5 year complete durability of response, in most of my patients. So I think this all relative, but if I see data from 42-month follow-up, it is definitely compelling.
And Niraj, when you talk about a complete response, I mean, how complete is a complete response? I mean, does it, in your mind, have to be like pristine, like there's not a millimeter of things left? Or are you sort of like, look, if that's a 90% plus reduction, that's good enough for completeness from my perspective.
I agree with you. I'm like, it's a near complete. I'm like, how will we know that small spot in the lung? We are not going to do a biopsy of that spot in the lung to see if there's still a metastasis left or not. Many times a scar tissue, many times benign lesions, which are just sitting in the liver. But we really have to do a biopsy to figure out if it's really a benign lesion versus malignant tissue or to metastatic tissue. So I think as long as I see the dominant lesions decreasing in size are more than 90%, I call it complete response.
Okay. No, I do too. And
Yeah.
and Raina, you brought up some of these other endpoints, that patients are interested in and whatnot. And Raj has talked about these kind of really durable, near complete responses. How do you view time off treatment as a goal for patients? I mean, that's not
Yeah.
something patients necessarily think about up front, but do you introduce that concept to patients when you're starting on a frontline therapy? And when do you consider, a discontinuation of therapy in somebody who's just having an ongoing response?
Yeah. I think this is a continuing evolving question in the field. Data from uh, uh, Checkmate 214, the way the trial was designed was that if you had actually a significant toxicity while you were getting your Nivo IPI, you actually had to discontinue treatment. And so this endpoint has sort of evolved of treatment-free survival, which is basically the time off the time that treatment discontinued to the time of initiation of the subsequent therapy. And there's many different ways that a patient can spend their time off therapy. They can spend their time off therapy without any toxicity. Maybe they have some minor toxicity, but that interval matters. And I think it's sort of becoming to be kind of a new endpoint in the context of the IO combinations, particularly people having to discontinue therapy for toxicity. I think one of the biggest questions we get in the clinic is like, okay, how long am I going to be on this therapy, doc? And so am I going to do this forever? And, it's always been like, well, kind of indefinitely until it stops working or you have toxicity. That's always sort of been our answer. But now this sort of benchmark of maybe around 2 years, which I think basically patients were allowed to discontinue treatment at the 2-year mark if they were responding. I don't think we yet have data on how those patients do. I think time is going to tell what happens, but I think it's a big question of what we, can we safely discontinue therapy in responding patients? I think to speak to that a little bit, we looked at that in the context of a multi-center phase 2 trial called Omnivore, and asked a question of, can we stop therapy in responding patients? The trial was small. It enrolled 83 patients. And for people who had a confirmed PR or CR within 4 to 6 months of starting treatment with nivolumab, they could be discontinued from therapy. And from the patients that were actually allocated to the arm to be discontinued, 42% at 1 year still remained off treatment. But the flip to that is that 60% weren't. And so how do we appropriately identify those individuals who we can safely stop therapy? That's, I think, an area where we critically need a biomarker, actually a biomarker of the extreme responders, because some people can do quite well. I think speaking a little bit to the durability of response, with the data coming out from the updated data from Keynote 426 at ASCO and updated data from Checkmate 214, at GU ASCO, as we look at these progression-free survival curves over time, like the Nivo-Ipi combo just seems to maintain a steady hazard ratio over time, over years, and there's really not a big shift in that 0.71, 0.72 hazard ratio. And when we look at the Keynote 426 data, we do see, progressively kind of worsening the hazard ratio. I think the most recent 0.68, I think, was the updated data in the intent to treat population. So it doesn't look as good over time with the IO VEGF. And again, speaking to that, are we curing patients? That the durability of the IO VEGF, I think time is going to tell what happens to those patients. But treatment-free survival matters.
Yeah, no, absolutely. And I think this is one of the really nice things about the longer follow-up from these studies that we'll learn. I feel like, this data is all still so relatively new. Even 42 months is really not that long in the natural history now of some of these patients, that I think there's a longer story to these regimens.